Welcome to Transforming Relationships. Our guest today is Dr. Mary Jo Peebles, a board-certified clinical psychologist and psychoanalyst based in Beacon, New York. Mary Jo is a graduate of Wellesley College, Case Western Reserve University, the Topeka Institute of Psychoanalysis, and 2 postdoctoral fellowships. So she has learned just a little. And I could go into more depth about all of Dr. Peebles' education and approaches. What I want to particularly emphasize in this intro is that she has taught for nearly 20 years at Menninger, was on the medical staff at Chestnut Lodge Hospital, was in private practice in Bethesda, Maryland, 25 years, has authored 4 books, which we're actually going to talk about in a moment, several book chapters, multiple articles um, on areas of trauma, therapy, psychoanalysis, psychodiagnosis, hypnosis. She teaches, she writes, she consults, and she considers herself a theoretical synthesist. And I don't know about you, but just listening to that, I can already hear that. Couple of books I just want to highlight before we introduce Mary Jo. One book is a book called When Psychotherapy Feels Stuck. I'm particularly grateful for that contribution. I think it's a topic that Mary Jo has written about in the book, in articles about the less quote unquote glamorous side of psychotherapy. You know, we often think, oh, psychotherapy, it's great. Connection is great. Intimacy is great, but Mary Jo really speaks to the complexity of those interactions and relatedness in psychotherapy. She's also written 2 editions of her book Beginnings, and there's a new classic edition coming out in 2027. Beginnings is really a masterpiece that speaks about the entire process of starting psychotherapy, what happens, what needs to happen, and what is important about happening, both from a procedural but also just as importantly a relational standpoint. And last but not least, she's currently working on a new book with the tentative title, The Messy Side of Psychotherapy. There is no companion book called The Clean Side of Psychotherapy. Who knows? Maybe after this podcast episode, that will be the next
That's
book in
really
line.
good. That's
And just
funny.
the last thing I want to say is I am personally grateful to Mary Jo for her mentorship and wisdom. We first crossed paths about 20 years ago, where just through complete chance and good fortune, I happened to connect with her to provide in the American Society of Clinical Hypnosis. We have this process of getting certified in clinical hypnosis, and the last process is a 20-hour individualized consultation. And I had the great fortune to work with Mary Jo, and I'll just share this really quick anecdote before passing the baton here. You know, I sort of went in and I thought, oh, okay, you know, we're going to do these 20 hours of supervision. Um, and Mary Jo asked me in the first meeting about my interests. And I come back the second session and she had created this personalized syllabus that must have been like 20 pages long with just this detailed amount of curricula based on my interests in reading. And I just thought to myself, my goodness, she was listening so
Mm, mm,
carefully
mm,
and gave me back what I didn't even know
Beautiful.
to learn. And that really set the stage for just a tremendous relationship. And just learning that has really set an incredible foundation in my career and identity as a psychologist. So I'm personally grateful to you, Mary Jo, and welcome to the show.
What a nice welcome you gave me. Thank you so much. I would never have known that vignette. And I thought you were going somewhere where I was going to quip because at Mentor's where I used to be in charge of different teaching syllabi where guests would come in and people would start to make fun of me because I would have the syllabus a year ahead of time. And so I was going to quip, and then you take this side turn and go into relationship, and I'm going, oh wow, okay. I'm really glad it landed that way. I hadn't really appreciated that about myself, so I thank you for that gift of telling the vignette. Yeah.
Absolutely. And it speaks to our show. And David, I'm sure that you have things to add as well, but I think it speaks to our show in the sense that our show is about transforming relationship, and
Mhm,
yours is a relationship that has transformed me. And
mm,
so I just wanted to speak to that.
mhm. Thank you.
Well, I'll take a quick few moments here to convey to you my appreciation. For me, interests that weren't well formulated, but they were there as I was moving into the field, is this question of people come in with expectations, often very lofty expectations. Will you help me to do this? Will you make this happen for me? Can you make this occur? I have been unable to realize this in my life. And I remember at the time being awash in all these different techniques and approaches. It's almost as if you have to pick a lane. Which is the lane you're going to go into? Is then that's who you'll be, or you'll be one of those.
Yeah.
And I remember being very, very struck that you were not a lane thinker. You
Mm,
conveyed right from the get-go that you have to be able to relate trans-theoretically.
mhm,
There's a process of change and there's a way to begin that's not definable by any particular theoretical allegiance or loyalty. And
mhm,
when I heard that, I thought, okay, she's speaking to my soul. So
mm,
I really feel grateful that from very early in my career, I had someone of your stature and your empathy connecting in ways that basically spoke to the human element that regardless of our training as psychologists or whatever we're trained in, there are really important ways to begin.
mhm,
And there
mhm,
are really important ways to allow that beginning to access the process of change. So that's my essence of
mhm.
my connection, my memory of you influencing my career. So thank you.
Oh, you're welcome, and thank you for again for that feedback. It makes me think I think I was lucky in one way that I landed in a postdoc. My first postdoc was actually down in Galveston at University of Texas Medical Branch. It was Children and Adolescent Hospital there. So not only did I get children and adolescents, but it was based on systems theory. Jay Haley, strategic family therapy. And that was the whole thing. Plus, the way they taught was one-way mirrors, a consultant calling in. They had
Yes.
extended families sessions that lasted over a weekend. So I got exposed to all this. And then on top of that, I'm actually going somewhere, but I just want to give, shout outs to these places. At Case Western Reserve, this was back in the 70s. When I was going to graduate school, there were three tracks. There was the psychodynamic, there was the humanistic, which was like Carl Rogers, and there was more of a cognitive behavioral track. And when I say Carl Rogers, I want to throw in the Gestalt stuff there too. But these tracks were running sort of simultaneous, and you were dipping into these different tracks. And what I culled from that, culled, Culled, was that where are the truths that overlap multiple theories, right? I mean, in the field of physical medicine, you don't say, "Well, I'm a biologist. I don't listen to physics." Or you don't say, "Well, we have this finding over here in cell theory, but we're not going to apply it to cancer because this is cell theory." They're always looking for the truths that cross-reference across different lanes. So it's not simply this is why I don't like the word eclectic. It's not simply drawing from different lanes. I'm looking for what cuts across the different lanes. These to me, it's like the principle of inference making. When you have convergence across different data sets, you have more confidence in your finding. So if you have these different data sets of psychodynamic, cognitive behavioral, humanistic, biological, if the alliance is the best predictor across all of those, that gives me a lot of confidence in going with that. So
Yeah.
didn't mean that sidebar, but
That's
you inspired it, by what you said.
Why do you think that our field has gotten so siloed? in that way. You know, you're speaking
Sure.
about common factors of
Yes.
psychotherapy. There's research on this by Bruce Wampold and lots of other people. You're
Mhm.
speaking about the power of the therapeutic alliance to heal, and that's something that happens no matter what your theoretical orientation is. But
Right.
why do you think the field is so siloed? Why do you think it's hard for people to get that kind of systemic education across the different approaches?
I'm about to blurt, but then it's okay to be controversial, right? Power and money. We get turf, variety, power, money. And I don't mean that really in any kind of intentional Machiavellian way, but if you can create a modality that you're coming up with, and it's the modality, and then you come into the 1980s and insurance companies are no longer covering any psychotherapy because the 80s were about corporations taking over and increasing their profits while shrinking their output. They began to do evidence-based therapy. And you get Jonathan Shedler, who talks about how faux a concept that was for psychodynamic therapy, but how economically driven it was for your clients. If the therapy you're providing isn't evidence-based, then they don't get reimbursed. Can they afford you? So why do we get siloed? I think we get siloed because we're competing for resources, money resources. When I say power, I mean name recognition creates followers, which creates workshops, which creates, and I'm not saying anybody's doing this in any kind of Machiavellian way.
Uh,
I think these principles operate. I don't know if they operate in other countries because I'm just not educated in that way, but I know it operated in our country across disciplines, right?
yeah, attentional resources. Um,
Nowadays, absolutely attentional resources. Right. Yeah.
I'm reminded of the phrase, I'm learning more and more about less and less until pretty soon I'll know nothing at all.
Mm,
Right. You ever
yeah.
heard that phrase, right?
I have not
But
heard that phrase, but it captures our culture right now in terms of the attentional resources, which is relatively new. Like we're talking 10 years old for this.
well, I'm wondering if we can pick up on that to delve into some of the clinical work that
Okay.
we do in the following way. My sense is that this specialization, this turf, competitive turfing, is in part a reflection of our sense that we have to find a place for ourselves in a world that seems harder and harder
Hmm.
to find a place in, right? So we have to find a way that identifies me as me. I'm unique. I'm different than. No one is doing this. This is an absolute, never before seen in the history of the universe product that I want to bring to your attention. Okay.
Mhm.
So if that is a cultural influence that is affecting the people that come into our office, when you think about how you encounter someone coming in, no matter what they happen to be coming in with,
Mhm.
do you sense that at the beginning of someone coming in, essentially saying, please help me,
Mhm.
that that issue of their individual identity is right there? Is that part of the beginning process for you? And if so, how do you respond to that to help them feel, yes, they are unique, but in ways that make them, in a sense, just another member of this human race that we're all a part of, right? So
Mm.
it's that balance between uniqueness and commonality. Do you get what I'm asking you? Yeah.
I think I do, but you know what would ground me if you can give me an example or pretend to be somebody. I'm a real, I mean, maybe everybody is, but I know that I'm a real blend of left and right brain. And
Hmm.
I'm not using that in kind of a literal sense. I'm talking about two ways of processing. And so I can jump into a role play and answer your question to talk about a hypothetical that's
Okay.
abstract and that I can't quite get a hold of is hard for me.
Well, if I think of someone who's coming in with a form of panic.
Okay, so they come in. So pretend you're that person, and we won't go on this very long, but
Sure,
just give me
that's
a
fine.
feel.
Okay. So I I I can't get a hold of this fear, it just explodes out of the blue. I'm just struck with panic in all these different situations, and I don't know what to do. I don't know that anybody has ever, I've never met someone who has panic like I have panic. Have you met someone like me? What can you do for me? I can't handle this anymore. I'm panicking all the time.
Yeah, no, I can tell that's happening right now in the office, isn't it? How are you feeling right now? Just keep going a little bit longer, and then I'll left brain you.
I'm on the edge of my seat. It's going to happen. I need something. It's going to happen again.
Okay,
It's already starting
so
to happen again.
it's starting to happen. Is it the same as when you walked into the session, or is it getting more as we're
It's
talking?
building.
It's building. Okay. And when you tell me about it, does it lessen or does it build?
No, you're making me focus on it. I don't want to think about it. I just want you to make it go away.
Uh-huh. And that's what you've been walking around with this whole time, your whole life, you're saying, that you just want to run away from it, get it to go away, because every time you think about it, it just gets worse.
Yeah, I don't want to have to look at it. It's just
Yeah.
too much.
Yeah. And I can see you slowing down a little bit right now, as we put it that way. Okay, let's pause there. I'm very much that what is happening in the room is going to tell me where we need to focus and how able the patient is to focus. So I am, and also research wise, if you've heard of, single case research, in other words, where the patient is their own control. So I am attempting interventions to see what your response is, you, the patient, to see what your response is. Did this work? Did this work? This is going to tell me what approach I might need to use. And as you begin to be able to connect with me, because you're not able to connect with me yet, you're so panicked. It's only the panic. The panic is in the room. That's who I'm talking to, is the panic. I'm not yet talking to you, but yet that is you, because you're telling me you are the panic. And I might even say that. And as you feel understood, my hope would be that I think what happened in that little micro moment is I think you slowed down, like in the role play. Your voice got a little bit more settled. It was a little bit more slowed down. And as we begin to open up an avenue of connection, I learn more about you, which is further going to inform me about how you can use the therapy, what kind of therapy you can use, and where we need to begin. Does that make sense?
Yeah, if I step out of the role I was occupying, what I was attempting to convey is this duality that I find always in the beginning, which is I am coming to see you as a person unlike any other person you've ever seen. I'm absolutely unique. That's what's horrific about my experience. And number two, I hope you've seen lots of people like me because otherwise you won't be able to help me.
Hmm.
And there's that tension between the two that I find is often at the beginning. So I love what you said about sort of the micro moment where you're exploring different trial balloons and observing my response to you in that moment. And
Yes.
it's the cue for what happens next, rather than saying, turn to page 74, we're going to do this.
Right. Right. Or, which would be just equally, I think, useless for me, would be to start asking you your history in the middle of that, like when you began to panic. And if I were to do that, if I were being honest with myself, I would be moving away from the panic because it was too much for me to hold.
Right.
Because I'm going to feel a little contagion there unless I know how to self regulate, right? So if I start going into your history, we all can be a little happier because that's what you expect in
That's
a
safer
doctor.
ground in a sense. Yeah.
Yeah. But what am I going to gain from that?
Right.
In terms of when I say, what am I going to gain? What am I going to gain in terms of what am I going to do with you to help you, and how helpable are you under what conditions, you know? So it's interesting. The question that you raised, David, I'm not sure I've ever felt the point of that arrow where there's a tension between, am I unique or can you help me? And have you seen a lot of people? I think I would need a little bit different role play because I know I would deal with it in some way. Go, go, go.
If you're listening, you can't see that I'm raising my hand, but I first thing I think it's just a statement of our profound respect for you that we're both like chomping at the bit to do role plays with you here in this episode. But that question of uniqueness and your desire to want to explicate that in a right brain way through role play was great. And David, I had this reaction where question of am I unique in a way that you won't be able to help me? I have, and I'm thinking of the APA ethics of very reasonably kind of hiding patient identifying information, but
Absolutely.
I'll just say I have a few patients for whom that question plays out in a slightly different way that I was hoping that I could role play with you.
Please,
Yeah,
yes, I welcome that.
because I think there's the one question of are my symptoms unique? Like, have you come across my symptoms and therefore will you be able to help me? But then
Mhm.
there's, I think, the deeper question that I think you were speaking to, but I want to present something that's a little bit of a
Okay,
twist on this, which is,
okay.
can you understand me?
Yeah.
And interestingly, this comes out with someone with whom I do have an alliance
Mhm.
and with whom I have been working with for some
Okay.
time.
Okay.
And yet there's just something there that it seems to kind of persist, no matter how much I sort of observe that with them and explore that. And I thought maybe I could kind of channel
Love
some of
that.
that essence and you might role
Yeah.
play here.
Yeah,
Would that be
absolutely, I love that, and I have 2 quick just things to kind of contextualize for people who are listening. I mean, one is I hope they can watch the YouTube of this so they can see the role play, which would be helpful. And
yeah.
the other is to remember, I don't know what you're going to say. I don't know what's gonna happen, and that's how clinicians feel in the first session. We don't know what's gonna happen, and just to be able to allow that, I think that's what I want the role plays to sort of convey as well, is that you don't have to know what you're gonna say. But then as we role play, I can describe what my thought processes were. Does that make sense?
Mhm, mhm.
Yeah.
And it actually, and I know that you're not referencing hypnosis, but it speaks directly to a hypnotic principle called utilization, which
Mhm.
is that, we really have to kind of be able to utilize what's happening in that shared intersubjective space.
I like that. Yeah, no, I like that a lot. Can I say one more thing? There was a mentor, and he has passed away now, sadly, too early. His name was Richard Maxfield, and he said, and I quote him in one of the books, he said, if I'm not nervous when I'm about to see a patient for the first time, then I'm not really present. And that has stuck in my mind my whole life, right? So let's begin. So, first of all, you say you're role playing a patient that you have seen for a while. Like,
I'm going to
let's
give quick background without giving identifying information. Yeah,
can I ask a couple questions
sure.
instead?
Yeah,
Is that okay?
absolutely.
Male, female.
Female.
Okay. Age?
Please.
Okay, 20s.
And
Yeah,
I'll
no, no,
say
no, just 20s.
specify. Yeah,
Yeah. Okay. And
young
have
20s.
you been seeing them months or years?
Let's say about a year.
Okay. Okay. And frequency?
Weekly with there was a disruption for a
Oh,
few months, but mostly weekly.
okay. And just a couple more questions. What did she come in with, is saying that she wanted how did she identify? And what did the 2 of you decide you were gonna work on? Just briefly.
The initial presentation was about significant anxiety, but as the work has evolved, it's gotten more about attachment relationships and
Mm,
difficulty of experience in relationships.
okay, so you found that there were more structural issues, so early attachment issues that were at the source of the anxiety. The anxiety was like the fever, and you discovered as you went on that there's other things going on underneath.
Well, what I'll say without being identifying is that this person has experienced two profound losses that create this reality where she is simultaneously connected to people but not connected to people and seemingly unsure if she's connected to people.
Okay. Okay. That's and then you are presenting, I mean, you are talking about her because you say, this is a good example of someone who is concerned that you understand her, even though you've been seeing her for a while. Is that correct?
And the specific way that that manifests, which is why I'm so eager to role play, is
Wonderful.
that there's a bit of a flatness in how she talks.
Mm,
And then she'll periodically ask me if I understand. And it's very disorienting because I have this sense of being really with her and
mm,
actually feeling her pain profoundly.
mm, mhm,
And I know you could say, oh, well, maybe, it's some kind of projective identification and you're holding the pain that she can't feel. And that might be true, but it feels more like something about my sense of being with her that I think that other people would pick up on.
mm,
She's not picking up on. And I think
mm,
that that's related to some of the deficits. And so I thought it would be interesting to
good.
role play that
Mhm.
to kind of get your thoughts about, what do you do with somebody who can't feel the relatedness that you're perceiving is there?
Yes, yes, and this happens a lot, actually. Okay, let's jump in. You're coming in for a session. It's the beginning of the session. And what name should I call you? Should Ruth? Is that good?
Sure, Ruth is great.
Okay.
Well, I don't know if I should break up with my boyfriend. I can't decide. He's really loyal and that's really good, but I'm just not sure if it's the right fit. And, I don't know if I really fit in with his family. Do you know what I mean?
I'm not sure yet. I'm not sure yet. What I can tell is that you look kind of troubled. You look a little bit vague or spacey about it, and I can't tell what you're feeling. Can you tell what you're feeling?
I don't know. I mean, I guess I'm not sure if I should be with him,
Mhm.
but I guess I don't really know if you get what I'm saying.
I do understand that you're not sure I'm getting what you're saying. What I'm curious about is what are you feeling as you tell me this story?
Yes, I feel anxious.
And describe the anxious to me.
Well, I don't know if I should stay with him or if I should see who else is out there.
Ruth, let me interrupt just for a second. I noticed when I said describe what the anxious feels like, that you went to your go to, which is to think about things and to try to problem solve and make those lists. I You didn't stay inside what you're feeling. I just noticed that happened again. Did you notice that? At least
And how do you know that's my go-to?
because we've talked about it before.
Well, it's hard to stay on the inside. I guess I don't really know what that's like or how that's supposed to feel.
Do you
Do you
ever,
know?
pardon?
Do you know? Do you
Uh,
know how that is supposed to feel?
Actually, I do, because I'm on the inside most of the time, as well as on the outside. I'm curious, do you ever remember a time when you were on your inside? When you're inside your inside? Do you ever remember a time ever?
When my dad died, that was really hard.
Yeah. Are you going there now? Yeah. 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 So you're feeling on the inside right now, and it's hard. Your inside is hard for you to feel. Well, then we want to take it in small doses, then, a little bit at a time. And we will pause there. I
Can
can hear
I
my
offer some observation from the outside looking
please,
in, so to
click
speak?
it.
My sense, having done a role play with Mary Jo just a few minutes ago, and then observing Mary Jo and Eric in this particular role play, I'm thinking about our audience. What
Mm,
is it that you're observing? Okay. One area of Mary Jo's expertise that I think is on display, but then the three of us are clinicians, and some of you who are listening may not be. What I'm observing is that when we come into a session with a clinician hoping to get better, we're bringing in our ideas about what Mary Jo called our go-to, our defaults, and she's meeting those defaults and saying there are other possibilities. And she had different questions that redirected attention to other parts of Ruth/Eric's experience that Ruth/Eric wasn't necessarily attuned to. So again, to the audience, my sense is what I just observed is the way in which we have to be able to stay in a place of uncertainty, a place where we can't predict exactly how this is going to play out, in a relationship that is safe enough that we're willing to be patient to see what else emerges, and how in the hands of the clinician that can be, using Eric's word, utilized so that other possibilities can be brought forward on the road to hopefully being able to change in a positive way. So if you listen carefully, you heard Mary Jo very sensitively responding to how Eric, for the second or third time, was asked to go inside. His head dropped, his face became flat. He rubbed his eyes. Something else was coming out, which Mary Jo was observing. And then there was that sense that it's hard to go inside and be there in connection to the memory that Ruth/Eric brought forward. So you just witnessed this space filled with the unexpected, filled with potential, filled with a story that's unfolding that's different than the story that the person came in with. And to me, that was a beautiful display of how we begin the process of change. So that's my outside in observation. Any thoughts from the two of you about that?
Let me defer to Eric first. And again, just asking Eric, I mean, that's very helpful, David, to hear that.
Okay.
And then just asking Eric, we didn't get a chance at the very, very end to me to ask, you okay? Are you settled after doing the role play? Because you were really inside the role play. And I'm curious what it was like for you in the role play, spinning off what David just said.
So my immediate instinct is to want to answer, but I actually think it's important for you to highlight to our audience why you asked that question of me.
Oh, you mean to left brain it right now and to say, why did I go there? What?
Yes, but I think the left brain would name the right brain
Oh,
experience
yes,
for
yes,
people because
absolutely.
they may not have that referential point.
I see what you're saying. The reason I'm hesitating is I realize I have an answer for you. Okay, I have an answer for you, and that is that when we ended, I was aware that you were in a space, and I didn't get a chance to say more than we're going to break. I wanted to give you a transition out of that space. I was very, very aware of helping you transition out of that space and trying to be sensitive to whatever feelings you may or may not, you, Eric, not Ruth, you, Eric, might have in that space. And I wonder if you're asking me to describe that because that's also what we do with our patients. We want to make sure that they're not left dangling with too much emotion, or they're not left dangling alone with any amount of emotion, that we're paying attention to being with them as they feel new things. That's how I would answer.
And now I feel like I can answer your question.
Okay.
So I had the benefit of holding the relationship that I, Eric, have with you as an anchor point.
Mm.
However, if I was more in my kind of Ruth mindset, although I think I'd be imagining Ruth's relationship with Eric, what I think would have been hard. Okay, I'm in left brain. I'm gonna get back in right brain here. I'm gonna get back in right brain. I am so in left brain right now. Okay. I was upset. It was for me in the role play, and I can totally identify with my client feeling this way, jarring. It was jarring because even though I, as Ruth, know that disclosure to be fundamentally true of missing my father, feeling a loss of my father, maybe wanting to push away, holding that on a day-to-day moment experience. There was something about how it came out in the discussion that
Mm.
I think for me in that role was unexpected, even though it was so glaringly obvious. And that was hard. It was hard to feel those things because I think in that capacity, I could only allow myself to feel so much at once.
Yes. And this is the kind of conversation we would have if this were a patient therapist conversation. Because notice, I didn't know what was happening inside you that led me to say, I want to check in with Eric to see how he's doing. I didn't know what it was, but I checked in. And you then respond and say that inside the role play, you were startled and it was unexpected. And the very unexpectedness, the absence of control over it, added to the feeling of overwhelmness and a little bit of frightenedness. So you helped me. We're having a conversation about what I didn't know, but I just simply observed what was factually and mutually observable. I didn't try to interpret. I didn't try to go inside and make a link to your past. I just said, I'm noticing what's mutually observable. And because you and I, Eric, and the pretend therapist and Ruth have an alliance, you tell me more about details about what that is that I noticed. And then together we begin to build what just happened. And as a therapist, I would then reflect in a few minutes or a few sessions. I would say, you notice that when we go inside that place, that feeling not being in control about what happens startles you and it adds to the discomfort.
I had this strange experience of my patient self role playing, my therapist self. And so when you were saying that, we all have an inside and I go in my inside, and I'm probably not
I'm always on my
you know,
inside.
I always go in my inside, and I'm wondering, is that something that you've experienced? Do you have a memory of that? The therapist in me is like, oh yeah, right. That's a really good thing to ask. We often ask our patients for these kind of examples, but in my role playing as the patient, here I am, I'm with you, like, oh yeah, you do that. That's something I should do. And then you ask the question, oh my God, I've got to come up with something. And then it's, oh,
Mm, mm.
do I ever have something? It's the something I don't want to think about. So that
Well,
was, I think, some of the jarringness of it.
well, hopefully in that patient therapist connection, we would get to the fact that you felt you had to come up with something, as opposed to invited and interested. And all of these little details, they're the ones that matter.
Mhm.
The little details that then we form together, we form the theory of you.
So on that point, what again, I'm imagining myself as like the person, the sign language translator in front of a group. I'm hearing what you are saying, and I'm translating to the group over here. What I'm witnessing is what to someone unfamiliar with what the therapy process can look like, that this can look mysterious, fluid, uncertain, unclear what's really happening here, what's going on. And so I want to offer sort of a meta level observation that in my work, I have this phrase emergent potentials, by which I mean, folks, we bring all of ourselves into the therapy session, whether we know it or not. We're used to bringing ourselves forward in a way where certain parts of us come forward and other parts are kept back. And what I'm witnessing is the way in which these two, in their interaction, are bringing into the clinical office all sorts of potentials that can emerge and be combined in new and different ways to create a different next step that can lead to something new, right? But again, notice the ambiguity. It's not like how a book on my shelf from now until the end of time, if you turn to page 84, it's always going to say exactly the same thing that's on page 84. life isn't like that, right? We're
Yeah.
creating an ambiguous process in which new things can emerge in new and different directions. That's my observation. Is that capturing, in a way, something that is part of what you're doing?
Can I say yes and? You
Yes,
know,
please.
That's
Yeah,
our favorite phrase.
yeah, yeah. Yes,
I wouldn't want to leave the listeners with the impression that I don't know what's happening, that
yes.
ambiguity is the whole of this space.
Mhm,
So to contextualize, this is a patient that I've seen for over a year. The pretend Ruth is so that's very different from a patient that is my first session, where I
mhm.
might describe a little more of what I notice happening and why that applies to their issues. I would not leave I don't think I would conduct a first session with an overflow of ambiguity for them. I would be describing for them the scaffolding of the session as I'm experiencing it. In other words, because this just happened between us, I think we might proceed in this way. Or because you raised this, I'm wondering how that might relate to what you said you wanted to work on. I would want to really provide scaffolding. So, um, again, too much ambiguity,
It's not, yeah,
it's threatening in the
yes.
beginning, you know. So we have to develop a relationship in which we understand that inside the ambiguity, inside not predicting, helpful things are going to emerge. That takes some developing with the patient over time. And I think it's a patient's right to expect that in the first session, I'm going to be explaining why this is even relevant to what they came in with. You know, that's I would want that as a patient. You know, I would want to understand what's going on. Um, there's one other thing, but I can't remember it now, but I'm sure it'll come up.
Can I ask you a follow-up question? I'm curious for our audience would be examples of scaffolding at an early juncture in the work. I mean, what would that kind of look and sound like?
Well, if this were a first session, I'm not knowing what to say. I'm just trying to separate out the logjam here a little bit. There would be the initial part of the session would be tell me a little bit about yourself. What brings you here? How did you hear about me? You know, those are grounding kinds of questions. They're here and now questions, but I'm not immediately rushing into, oh, I noticed a look on your face because they don't know who I am, you know? And that's a very, one could argue it's a bit invasive. You know, you don't have a doctor, you know, a internal medicine doctor saying that right off the bat. Gauge a person's comfort or discomfort with being seen. So, not how are you, but what brings you here? How did you hear about me? What are you hoping for? Wait, and then about maybe if I'm making this up. It's not a rule, but let's say about a third of the way in, I might say, well, I might go into observations and see how tolerable those are. And just notice, I notice you teared up a little bit there. Am I picking that up correctly? Whenever I make an observation, I always ask them for two reasons. One, it's polite, you know, I don't want to be intrusive. But the other is I want to build their own awareness of themselves. And there's actually number three, I want to test out how much awareness of their own selves do they have. So how much are we going to have to build? So everything I'm telling you is kind of the scaffold. If they were to say, why did you just ask that? I would have an answer that relates to why they came in and what I'm looking for. And I would tell them that answer.
What might that answer be for someone like that?
Well,
Someone who, and because you're so good at kind of naming these kind of non-verbals, somebody who says, "Why did you ask that?
give me the that so I can answer you. Any that, you can just make up
Why,
something.
why did you ask if I was tearing up?"
Well, I noticed your eyes seem wet, and I didn't want to not notice that with you if you were feeling emotional.
I didn't notice my eyes were.
Okay. Okay. Is that something, is it unusual for you to, you know, notice what you're feeling or not? I'm just curious.
Well, I guess it's just kind of weird to have somebody noticing something that I'm not really aware of.
Well, you're right. That actually can be very, very not just weird, but feel a little bit invasive, maybe. I mean, I apologize. I didn't mean to step into you in that kind of way.
Well, I don't know if you need to apologize. I guess I just don't really know what you're talking about.
Well, what we are talking about right now, what's happening between us, may have something to do with that feeling of joylessness that you described coming in with, that you're not feeling any joy in life. And so I kind of am paying attention not only to what you can tell me about that, but also what you're showing me about that. And sometimes we show things that we can't really describe. And I like to pay attention to that so that so that together we can start to notice what you are able to show me that you may not have all the words for.
So how do you do that?
Well, it's what just happened between us. I just noticed that your eyes were seemed kind of wet. There were no tears coming down, but they kind of glistened a little bit. I couldn't help but notice it.
Eric, is it okay if I come in here? Right, Joe? Okay. So again, in this role that I'm assuming here, I'm sort of bringing in my perception of our audience. So again, what I'm wanting to invite our folks to notice is a kind of duality that Eric is displaying, conveying in words and in nonverbals, both wanting to be seen and not wanting to be seen. In a episode that we had recently, someone who works on the international stage bringing very polarized parties together, where he's been asked to come in and create some better conflict management, conflict resolution process. He said one of the biggest things that I'm often having to do is to help both sides feel acknowledged, because until there's an acknowledgement, they can't let their guard down and begin to hear the other differently so that maybe some new possibility can emerge. And in a way, I felt that that was on display here too, that Mary Jo is offering moments of acknowledgement, testing that. Some Eric accepted, others he reacted with essentially, "What are you doing? Why are you doing that?" So we see on display this tension between our need to be seen so that we can feel that what we're feeling is real through the eyes of the other. And at the same time, don't look so closely. You're making me uncomfortable. I don't want to be seen that way. And that's part of the tension, not just therapeutically, in marriages, in whatever relational context we're talking about. Those are things that are there. I just am struck by the universality of what we're witnessing here.
Interesting.
And what I was trying to model was a hard dose of I don't know what this is
Mm-hmm.
with a reasonably strong dose of I don't like that, but
Mm-hmm.
enough of a window where there might be some room for something to happen.
I like that. And if the audience can or the listeners can notice, and I don't know if people picked up on this, and I bet you did, Eric, perhaps, is that when you first gave the hard pushback, did you notice that I was caught off guard? Yeah.
I was trying to throw you off a little bit.
I want it. No, no, that's what I want. Yeah. And that's okay. Because I'm noticing that I'm caught off guard. What I did internally was take a breath and try to come back to center. But the being caught off guard is going to be at play somewhere. If this is a beginning session,
Uh-huh.
you're catching me off guard. You're unsettling me is probably going to occur again and probably going to relate in some way to your presenting problem.
Yeah, and I think that I wasn't even necessarily just because of the back and forth having totally conceptualized my background in that role play, but what I really liked was your apology, because your apology wasn't over the top, but it also wasn't sort of defensive. It was just kind of like, hey, seems like something happened that you didn't like, and I'm sorry for that. Can we understand that in a safe way? Which I
Mhm.
think then made it safer for me in that role play to kind of move towards that feeling, that experience.
For those who are listening that know about rupture repair, this is a first session, and already there's a rupture. And the best way to proceed is to acknowledge the truth and the reality that there was a rupture, that you felt taken aback. I had done something, not malevolently, but I had done something that created tension in you. And so I acknowledge that so we can find some common ground, to go back to your idea, David, to find some common ground where we can use that moment. Because I keep wanting to emphasize, and in response to what you were saying, David, everything that's happening in that first session, I am tracking because how this relates to what the patient came in with. Because I'm wanting to form a treatment plan that's responsive to what you said you're struggling with, not a treatment plan based on just what I think you might actually need or what a theory is or a manualized approach. I know I keep repeating this, but you come in with something that you're saying you're struggling with. You are going to show me in that first session or in the first 3 sessions, you're going to show me what gets in the way of getting there. I want to pick up on that, and you're also going to show me how, under what conditions you best work. And so I want to learn those couple of things and then formulate out loud with you. I think I made up the thing when we were role playing. I said joylessness. Uh, uh, you know, so when we get to, I think we can work together if you're willing. I'm role playing now. You talked about the joylessness, and I think there's something, given what we went through, if you noticed it with me, and you did, about wanting to connect, but just that wall keeps coming up. And it's not simply a wall, there's that pushback. There's that pushback. We don't know yet what that pushback is about, but in this process, we could find out and see if there's some other way to keep you feeling protected, other than having to push back and then push away the other and then push away all the feelings and then feeling kind of left alone in life. So I would say pull them together like that. That's the scaffolding. Now, it's not a DSM, but it's the use of diagnosis. And Carl Menninger was talking about this in the, it's the use of diagnosis as an understanding of, what this patient is coming in with, under what conditions they can work, and what is it that's underlying that is causing those symptoms. So what do we need to work on? And there's more to it than that, because they may have coverage for 10 sessions. And what I just described could take 2 years. So if they have coverage for 10 sessions, say, well, we could do a piece of work now. Let's do a piece of work on just identifying this pattern over and over again so that you can take that with you and begin to notice it in your life. So I'm making that up.
I'm curious about how you would explain that short-term frame of work, of short-term frame of therapy to a patient that has that limitation. The limitation of, well, I can only really afford to do 10 sessions, or my insurance only covers 10 sessions, or, maybe I'll decide to do more therapy, but I'm not sure at this point I want to do more than 10 sessions. How would you kind of
Mhm.
explain what the two of you could quote, and I hate this word, but quote unquote do that
Mhm.
would be valuable in 10 sessions?
Well, I'm already stuck on, those are 3 different questions that the patient's saying. Those are 3 different patients. One says, I don't know if I have the money. The other says, insurance will only cover it. And the third patient said, let me see what 10 sessions feels like, and then maybe I'll sign on for more. So those are 3 different patients. So I'd say 3 different things depending on that.
So can I
I would go ahead.
go ahead? All right. So what I'm struck by is this: throughout our conversation so far, I keep running through my mind, in what ways are we talking about the process of change? What does that look like? what fosters that, what inhibits that. So what's coming to my mind right now is this. If I dip back into my training in neuropsychology and neurobiology, I think about what we call the error detection system, okay? Where there are beliefs and experiences and expectations that shape how we interact. And we expect what we expect to happen again.
Mhm.
And then something happens in the presence of a skilled therapist where what we expect doesn't happen. And our system is all over that moment because something different is happening. To me, that's an incredibly powerful, pregnant moment when all sorts of neural networks in the brain are saying, oh, whoa, 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 what is going on here?
Mhm.
And I feel that that is a maximally defensive and maximally flexible moment where, depending on how we interact, something new can happen so we can assimilate it not as an error bad, but an error in what I believed about myself or my possibilities or my circumstances. Maybe that is erroneous and something new and better might be here, whether that's at a bigger level or, as you were alluding, Mary Jo, if we're limited to 10 for whichever of the three clients it happens to be, we can organize a treatment plan around that error detection and turn it into a positive process. That's what I'm observing.
I have some thoughts as you talk, you know?
Yeah, yeah.
As I hear you shifting, and it's a helpful shift. We have been talking, I think, so far about initial sessions
Mhm,
and almost like treatment planning and what that looks like,
mhm.
and also what working with the process looks like, as opposed to working with a manualized approach or a
Right.
history-taking approach. And you're wanting to shift it to change, what allows for change. So it was one thing I kind of noticed that we could make that shift now and talk more about change, what allows for change. So the second thing, I had three things I noticed from what you were saying.
And is it possible to just interject for a moment with
Yeah.
that piece? And I don't want to disrupt your thinking about the others, but I think when we talk about process, it's an interesting process question for us, right? We had this grand plan at the beginning that our episode was going to be about why change is so hard. And it's been hard for us to change, to talk about change. Instead, we've been talking about the beginnings of therapy, as you showed in the role play, the first role play or the second role play, also talking about the process of therapy that's been going on. And I just want to put out there that perhaps we continue on this theme because we're an hour in and I feel like we're just hitting our groove here. And you come back for another episode and talk with us about why change is hard.
I would love that. That would be great. And that's the kind of spontaneity that I think if we create space for in therapy can take us in the new directions that David's talking about. That where there's potentials, emergent potentials. Hope and Sugarman, I love that article in
Yeah,
2015.
yeah.
It was I quote it all the time, where they talk about the orienting response. It's exactly what you're talking about, where there's a startle and the connections momentarily are open because it's like, what is this? What the heck just happened? And in that moment, you're right, it's a pregnant moment. But but this is for our next podcast. Change is hard. There's pregnant moments and there are miracle moments, but can they last? And that's where we talk about what helps change happen. Not just catharsis, not just these light bulb moments. It's rare really that you'll have 10 sessions of therapy, there'll be a light bulb moment and your whole life is changed.
Exactly. Epiphanies. Yeah.
Yeah. It's not that it's never happens, but it's rare.
Yeah.
And I don't want people to feel disappointed when they don't have that moment or they feel like it hasn't changed them because change requires something additional. So that's for our next podcast. That's the teaser.
Beautiful. Beautiful. Yeah. Yeah. Well, I think Bateson, one of his lines is it has to be a difference that makes a difference, right?
Yeah, it's great.
So We can have a moment or two in the session, and that's a difference. But then there's the issue of durability,
Absolutely. Help
persistence.
to stick,
Yeah, exactly. Yeah.
which is a structural change. Well, I'm starting on change now, but I'll go the structural change. And by structural, we're talking about the bones of the psychology of the person, but we're also talking at a neurophysiological level. Because change that sticks is alterations in the neural network.
Can you just elaborate a bit more on each of those for our audience? I think a lot of people won't know what you're referring to when you talk about the bones of the structure.
Okay. Are we doing well on time or?
I think we're okay.
Yeah.
Yeah.
Okay. Okay. Well then, so the there's a lot there to unpack. Okay. I'm going to make it very simplified because there's a lot to unpack that really helps understand what I'm about to say. But there are to make it easy, there are ways that we proceed in the world. Go back to your idea of beliefs that we have. There's ways that we proceed, that we take in reality, that we take in what's happening between us and another person, how we interpret that reasoning, how well we manage our emotions, under what conditions, our level of maturity in terms of relationship. These are all developmental things. Our moral sense. So these are things that grow over time. They're kind of like what I call the bones, the psychological bones of a person, and change that lasts creates change in those developmental aspects of how a person functions. Like, for example, I'll give a brief example. It may or may not bring it home, but in terms of perceiving what we see happening. I had a patient talk about how dismissive her uncle was. And anytime she raised something positive, he just sort of dismissed it as, yeah, just sort of rejected it outright. And she told me about a text he had sent her that had done just that. And I said, is it okay? Can I see the text? Can we look at it together? And she pulled it up and she was hesitant because she felt immediately, she was able to say this later, she felt that I was questioning, her report, which has a germ of truth to it. It's not that I'm in a judgmental way questioning it, but I wanted to see if there was any difference between the words of the text and how she read it. So I said, would you like to read it out loud? Would that be better? Would that be easier? I wanted to give her more control over that. So she read the text out loud, and as she read it, her face changed a little bit, but not a lot. And I said, did you notice that he said X? Did you notice that word that he used? Did he notice that he did thank you? And again, I was doing it carefully so she wouldn't feel judged, but helping her see the gap between the words on the text and how she had perceived them, literally how she had read the words. And this is a very, very, very smart woman. So that is perception. That's reality testing. It's not about hallucinations. It's just about being able to see what's there. That over time, she began to catch herself. Did I really read it completely? Did I really hear what they said? And that ability to, checks and balances on her own self, imagine it creates a whole new interpersonal world for her because she starts to hear and take in things that she had been dismissing because she had expected to be dismissed. Does that help understand? That's a vignette about one of the bones of psychology.
I was really relating because actually that has happened to me a number of times where I've had patients who are, you know, emotively telling me about something that happened in a relationship that was problematic. And then they say, sometimes like, I don't have to prompt them. They say, yeah, let me show you the text.
Mm-hmm.
And, we obviously talk a little bit about, well, what's important about showing me the text and why is that going to help? But, then invariably what happens often
Mm-hmm.
is as I am reading the text
Mm-hmm.
with my patient watching carefully my facial reaction as I read.
Mhm.
It's a very
Mhm.
interesting process dynamic. I am thinking to myself, this is a little bit more complicated.
Mhm.
This is a little bit more nuanced.
Mhm.
How am I going to relate that back in a way that they can take in? And
Mhm.
so, what, with some obvious variation depending on the person's bone maturity and personality dynamics, sometimes I just need to just sort of stay with the hurt because they're not able to. But sometimes, I'll say something like, yes, I can really see how painful that was to receive and how painful that is and how important it was for you to show this to me. Pause.
Mhm.
Yeah. No, I'm noticing something else here that's kind of interesting. Pause.
Mhm.
Would you be curious to know what I'm picking up in this text? And I do that in that certain way because I want to see what happens. Some people may either say no, they're not curious, or they may show me they're not curious. Okay,
Mhm.
that's a
Mhm.
different response, but it opens it up to the possibility that we can make space for your pain and for the curiosity of another perspective where there may be something happening in the way that you're taking in this information to what you're speaking to, Mary Jo, that may not be taking in the entirety of it or maybe kind of siloing it or, there's so many opportunities to explore. So I think it becomes like a psychoeducational moment, but you have to just be so kind of intentional and delicate and making
Mhm.
sure to kind of hold the hurt so that they don't feel that you're not hearing them. That was my reaction to what you were sharing.
There was a saying we used to have at Menninger's to be as supportive as necessary and expressive as possible. And you just talked about that in a way that you want to support their feeling safe and their self-esteem so that they can then take a leap and expressive meaning in psychotherapy, expressive means exploratory into things they hadn't thought about. Supportive means acknowledging where they are and what they do know. Exploratory going into what they don't know, right? To make it very simplistic. But you were being as supportive as necessary to their self-esteem and to their feeling of hurt, and then experimenting with how able they were and how far they could go to explore what they had missed and what they weren't in general aren't able to see in people's responses to them. And this is just this what we're talking about with the text messaging is an example of a patient showing us what happens as opposed to telling us what happened. Because we can only tell when we describe what happened to us, we can only tell you, I can only tell you what I know I've seen, and I can only see what I'm used to seeing.
Yeah. Yeah, there's that perceptual constancy that in other settings is really helpful for us to be able to operate in a world that's changing all the time. But so that we don't become psychotic, we have to sort of have a sense of constancy, but it
Yes.
also becomes the obstacle that gets in the way. So as I think about the Mary Jo Part 2 conversation, which I can't wait to have, what I'm imagining is us bringing in for our audience a sense of what are some of the frames that we keep in our mind that potentiate, that make it possible that however this person comes in whatever way they present, we can have that occur within a context where other possibilities can be brought forward and move in a direction where change is possible. You've mentioned safety. We've talked about being seen. We've talked about being able to explore and experience, to get out of the so-called left brain into the right brain experience of our past so we can have a potential experience of a possible future. I'm remembering, I think, Dr. Herb Benson, who wrote years ago, The Relaxation Response. right?
Mhm.
A cardiologist, was he at Harvard? He may have been at Harvard. But there is something he said like, change is always possible. The challenge is finding the door through which it can enter, right?
Mhm. Mhm.
And my sense is that that theme has run through our conversation today.
Mhm.
So I want to walk through that door in part two. What do you think?
I would love that. That's a great segue.
Yeah, yeah,
So as we get ready to end or pause for now, the door is open, waiting for the three of us and for the many people listening and watching to walk through together.
yeah.
That's
Great.
lovely. I look
That's
forward
great.
to it. Thank you for creating a safe space to have this conversation.
That's lovely. That's great.
As always, thank you so much for tuning in. We look forward to catching up with you again in our next episode. A quick reminder, while we are both doctors of psychology, this podcast is not a substitute for professional medical advice, does not offer diagnoses, or engage you in actual treatment. The conversations, the opinions of our guests, and any information that we share here are meant for your general knowledge, your learning, your inspiration, and your motivation to put some of our ideas into practice in your day-to-day life. Remember that everybody's body and everybody's personal health journey is different, so what works for one person may not be right for the next or for you. If you have questions about your health, any psychological or medical condition, or any changes that you're thinking about making to your lifestyle, your diet, your exercise routine, your medications, or some other aspect of your life, it's always best to talk with a qualified healthcare professional who knows your personal history. Never ignore or delay professional advice because of something you heard here with us. We want you to enjoy the show and to walk away with useful insights, but ultimately, you are responsible for your own health decisions. Please use your best judgment, stay curious, and always listen to your body. Take care, be well,